Hello, this is my article review on a new experimental PCL surgery. So, the PCL is a main knee stabilizer in translational and rotational movement. It has broad, thick collagen fibers, making it the strongest knee ligament. It's also paired with an intrinsic healing factor due to its vicinity to an artery, which is a rarity for ligaments. Due to those two factors, though, one of the most common issues is doctors simply state patients should rest it off and avoid surgery, which is works for some, but is a common issue when it later develops to PCL laxity and a tear. And if it's a tear, it leads to a PCL reconstruction, which is a grafting process that can lead to also PCL laxity. This is where a Yale research group developed a new method to address mid-substance PCL tears, which is the most common type of tear. In figure 1, you'll see the general idea. It's a bidirectional ring with an adjustable loop lengthening device. The purpose of which is to be able to capture both sides while still being able to maintain tension with the least amount of recovery time, which minimizes the reduction of tissue. They specifically hypothesized their PCL repair will offer original stability without an internal brace pulling so hard. In their methods, they state the use of fresh, frozen human cadaver knees under 5 conditions: intact PCL, PCL deficient, PCL with internal bracing and sutures, their new PCL repair with their internal bracing, and simply just their PCL repair. Their testing setup was comprised of specimens being mounted on a rig, and their posterior tibial translation was measured under the load of 134 newtons at 90-degree flexion. They sampled each 8 times, which was determined to be sufficient by previous studies. So these are the results. A normal PCL was moved 3.34 millimeters versus the horrible 16.9 millimeters when the PCL was deficient. All 3 repairs significantly reduced the excess PCL deficient posterior translation. And just the PCLR was 3.14 millimeters, and the internal bracing plus the PCLR was 2.98 millimeters. Despite internal bracing helping, it was still over the intact movement with 4.66 millimeters. The authors concluded the direct mid-substance repair of the PCL, when combined with suture tape and internal bracing, can biomechanically restore the native level of stability. This is important because it challenges the traditional assumption that they can't be repaired, and it supports a trend towards primary repair, which is essentially their process. The internal brace likely acts as a load sharing device, protecting and healing the ligament during early motion. So, some of the limitations with this study are the fact that this experiment was done on cadaver models, which does give the useful force data, but it doesn't reflect in vivo testing. This, alongside the small sample size, can be improved, which will offer a better view into how the repair works. And since this was simply an experiment to see if it can take the force at all, there was no long-term testing. And this was, again, because it was a cadaver, there was no information about how this process will heal over time. So the applications that I took from this study is that minimally invasive mid-substance PCL repairs can achieve intact levels of stability, which changes the conventional mindset of PCL tears require the full grafting reconstruction. It's an important advancement in ligament preservation, showing that native tissues, when stabilized, are capable of the original ligament weight. If this were pushed out today, I can see it being used in sports medicine, by promoting less invasive surgeries and potentially reducing the rehab time and post-operative stiffness, which again was a major complication of the grafting reconstruction. Thank you, and this is my citation.